Welcome to the deep dive. Today we're taking a close look at the huge updates really changing the landscape of diabetes care. We're focusing mainly on the brand new 2025 American Diabetes Association Standards of Care. Our goal here is to show you why just thinking type 1 or type 2 diabetes is, well, honestly, it's pretty outdated and potentially risky. There are new diagnostics, genetics, amazing new tech. It's forcing a whole rethinking of how we screen, classify, and manage this whole family of diseases. We want to unpack the really critical details that make the difference between a spot-on diagnosis and a potentially dangerous misstep.
That's absolutely right. What we have in front of us is, the gold standard clinical guidance, the ADA standards, but we're also pulling in the latest research on pathophysiology, genetics, and these really advanced treatments like AI-driven insulin pumps. Diabetes is just so complex now, we have to focus on precision medicine. So the real challenge we're tackling today is getting clarity on the technical side, which test to use, when it's the right one, and why getting that classification exactly right determines the whole treatment path for you or someone you care about.
Okay, let's unpack that, starting right at the beginning, the actual diagnostic tools. So for screening or diagnosis, the standards mention three main players: fasting plasma glucose, FPG, the 2-hour test during an oral glucose tolerance test, the OGTT, and A1C, Y3. And what are the real-world trade-offs?
Well, they each give a slightly different picture, different time windows of glucose exposure. And importantly, they don't always point to the same conclusion. The FPG, the fasting test, it's simple, cheap, widely available, but you need to fast, obviously, and the results can bounce around quite a bit day to day. Plus, there's this issue with glycolysis, the glucose in the blood sample breaking down if it's not handled quickly, which can mess up the reading.
Right. And the A1C, that seems like the go-to for convenience these days, doesn't it? What are the big upsides, but maybe more importantly, what are the serious catches people might not realize?
The convenience is huge. Yeah, no fasting. And it gives you that longer term view, like an average glucose level over the past 2 or 3 months. Stable picture, but it's more expensive. And globally, not quite as available everywhere. Also, critically, it's actually less sensitive than the 2-hour OGTT for picking up diabetes or prediabetes. And here's the really big catch. A1C depends entirely on your red blood cells turning over at a normal rate. So anything that messes with that, like certain types of anemia, if you've had major blood loss recently, if you're on hemodialysis, some HIV treatments, even pregnancy later on, all those things can make the A1C result completely unreliable.
Okay, that's a really critical point right there. So if you're dealing with anemia or you had surgery with blood loss, that A1C number might look fine, but be totally misleading.
Exactly. In those cases, you absolutely have to rely on the plasma glucose test, the FPG or the OGTT. You just can't trust the A1C. But going back to sensitivity, this is probably the most important diagnostic nuance. That 2-hour plasma glucose test, the OGTT, it actually diagnoses more people with prediabetes and diabetes compared to just using the FPG or A1C cutoffs.
And why does catching those extra cases matter so much, especially at that prediabetes stage?
It matters because the big prevention strategies for type 2 diabetes, the diet, the exercise, lifestyle changes their effectiveness, has primarily been proven in people identified with something called impaired glucose tolerance, or IGT.
And the OGPT is the test that specifically picks up IGT.
Precisely. So if you want to find the maximum number of people who could really benefit from early intervention to prevent type 2, the OGTT, despite being less convenient, is still incredibly valuable.
Got it. And just quickly on those rapid A1C tests you sometimes see, the point-of-care devices.
Right, those need a mention. They can be used for official screening or diagnosis, but only if the specific device is FDA approved for that purpose. And crucially, it has to be done in a lab or clinic that meets CLIA standards.
CLIA.
Yeah.
That's the federal quality standard for labs, right?
Yeah.
Making sure things are done properly by trained people.
Exactly. It's not just, a casual check. It needs proper quality control. And this all leads to something important. If someone's A1C results and their direct blood glucose readings are consistently off hum, they just don't seem to match up, that's a red flag. You need to investigate further. Look for those A1C interferences we talked about, or maybe something else entirely is going on.
Okay, so that diagnostic detective work is vital. Because even once you have a diagnosis, the next step classification seems even more critical now. We used to just think T1D, T2DD, but the standards are saying clinical signs alone could be really misleading.
That's the huge challenge now, the sheer heterogeneity of diabetes. It's not just 2 neat boxes. I mean, clinical studies show something quite startling. Around 40%. 40% of people who develop type 1 diabetes after age 30 were initially misdiagnosed.
Misdiagnosed as type 2.
Yes, exactly. And treated as type 2.
Wow, 40%. That's genuinely scary. Because if you have type 1 and you're not getting insulin because everyone thinks it's type 2, that's life-threatening.
Right.
Risk of DKA.
Diabetic ketoacidosis,
Yeah.
yes, extremely dangerous, which is why the standards now strongly recommend autoantibody testing, especially for adults who might have overlapping features, maybe diagnosed younger than typical T2D, or they've had unexplained weight loss, or even presented with DKA.
So you need to check for those antibodies to see if it's an autoimmune process attacking the insulin cells.
Precisely. We need standardized tests for the key islet autoantibodies, things like GAD65, IA2, ZNT8. These are the markers that tell us if the immune system is mistakenly destroying the beta cells. Finding these is crucial for getting the T1D diagnosis right, regardless of age.
And this antibody testing actually lets us spot type 1 even before symptoms show up, these pre-symptomatic stages.
Yes, that's a major advance. The ADA now defines these stages. Stage 1 T1D is when someone has 2 or more of those specific autoantibodies, but their blood sugar levels are still completely normal glycemia.
But they already have the autoimmune process starting.
Exactly. And even with normal blood sugar, their risk of developing symptomatic clinical T1D within 5 years is already about 44%.
44%, wow. Okay, and stage 2.
Stage 2 is when they still have multiple autoantibodies, but now their blood sugar is starting to become abnormal dysglycemia, but it's not quite high enough yet for a full diabetes diagnosis based on the standard cutoffs.
So antibodies plus wonky blood sugar, but not full diabetes yet.
Right. And at this point, the risk escalates dramatically. We're talking roughly a 60% chance of progressing to clinical T1D within just 2 years, and about a 75% chance within 5 years.
That stage 2 window seems incredibly important for potential intervention then, before the beta cells are completely gone.
It's a critical window for research and potentially future therapies, yes. But there's another classification challenge where the clinical picture can be deceiving. Monogenic diabetes, sometimes called MODY.
Ah, yes, the genetically driven forms.
Right. Caused by a mutation in a single gene. It often looks like T1D or P2D, especially in younger people, but the key clue is often a strong family history, following what's called an autosomal dominant pattern, like seeing diabetes across multiple generations.
And why is nailing this specific diagnosis so important?
Because genetic testing is crucial here. If you identify the specific gene mutation, like HNF1A MODY or HNF4A MODY, the treatment can change completely. Instead of lifelong insulin, which might be the first assumption, these individuals often respond incredibly well to simple, inexpensive oral medications called sulfonylureas.
So getting the genetics right means potentially avoiding insulin altogether.
For certain types, yes. It leads to much better, more personalized, and frankly, more cost-effective management. It really highlights the shift towards precision medicine.
That really is foundational. Okay, let's shift gears slightly and look at 2 specific high-risk situations the standards call out. Gestational diabetes, GDM, during pregnancy, and post-transplantation diabetes, PTDM.
Right. Starting with GDM, diabetes that develops during pregnancy. Now, it usually goes away after the baby is born, but having GDM is a major red flag for the mother's future health. It significantly increases her risk of developing type 2 diabetes later down the road.
And there are immediate risks, too, during the pregnancy itself.
Oh, absolutely. For the mother, risks like preeclampsia, higher chance of needing a C-section, potential for hemorrhage, and for the baby, risks include being overly large macrosomia, which can lead to complications during delivery, like shoulder dystocia or birth trauma.
So the stakes are high, which leads to this debate about how best to screen for it, the one-step versus two-step approach.
Yes, it's an ongoing clinical discussion. The ADA actually recommends the one-step strategy. This involves a 75-gram oral glucose tolerance test for all pregnant individuals not already known to have diabetes, usually done around 24-28 weeks.
And the rationale for the one-step?
It's based on diagnostic criteria derived from a large study, HAPO, that directly linked specific glucose levels during pregnancy to adverse outcomes, like large babies or C-sections. So the thresholds are set to identify women at higher risk of those outcomes.
Okay, seems logical, but what's the downside or the controversy?
The big consequence is that adopting the one-step approach dramatically increases the number of women diagnosed with GDM. Incidence rates can jump from maybe 5-6% with older methods to 15-20% or even higher.
Wow, it identifies way more cases.
Yes. And then there's the two-step strategy, which many places still use. That usually starts with a 50-gram glucose challenge test, no fasting needed, and only if that's positive do you proceed to the longer 100-gram OGTT.
So what's the core of the debate then? More detection versus proven benefit?
Kind of. The tricky part is, while the one-step method clearly identifies many more women with GDM based on those outcome-linked thresholds, research hasn't definitively proven yet that diagnosing and treating all these extra cases actually leads to significantly better overall health outcomes compared to the two-step approach. It's a classic dilemma, more diagnosis versus clear evidence of improved population health from that increased diagnosis. Clinicians are still navigating that.
Fascinating trade-off. Okay, now briefly on the other scenario. Post-transplantation diabetes, PTDM.
Right. After an organ transplant, high blood sugar hyperglycemia is incredibly common, especially early on. Up to 90% of kidney transplant recipients might experience it in the first few weeks, often due to the high-dose immunosuppressant drugs needed.
So you don't diagnose PTDM right away then?
No, it's best to wait. Formal diagnosis should ideally happen once the patient is stable on their long-term maintenance immunosuppression regimen, usually at least 45 days after the transplant, and also when any acute infections have cleared up. You need things to settle down first.
And which test is preferred here, given all the potential interferences from surgery, meds?
The OGTT. The oral glucose tolerance test is definitely the preferred test for diagnosing PTDM. Just like we discussed earlier, things like the surgery itself, medications, potential anemia post-op can all affect A1C, making it less reliable in the specific setting. So OGTT gives a clearer picture.
Okay, so moving beyond diagnosis and classification, this is where the pace of innovation and management gets really exciting. Of course, the foundation is still crucial, right? Things like diabetes, self-management, education, and support DSMES, getting nutrition counseling, regular exercise.
Absolutely. Those lifestyle cornerstones are non-negotiable. 150 minutes of moderate intensity exercise per week is still the baseline recommendation. For T1D, carb counting remains vital for insulin dosing. But yeah, the technology is moving incredibly fast, especially in type 1 diabetes. We've reached a point where technology isn't just an add-on, it's really considered the standard of care now. Continuous glucose monitors, CGMs, and automated insulin delivery systems, aids sometimes called the artificial pancreas or closed-loop systems, are now seen as the best available treatment for most people with T1D.
Better outcomes, less burden.
Generally, yes. Improved glucose control, more time spent in the target range, reduced hypoglycemia. It's a game changer. The new standards even have specific recommendations for using aid systems during pregnancy. Ideally, using a system that has a pregnancy-specific glucose target programmed in. That shows you how quickly this tech is being validated and adopted.
That's pretty amazing. And what about type 2? The focus there seems to be shifting too, right? Beyond just lowering the A1C number.
Oh, massively. This is probably one of the biggest shifts in TTD management philosophy in years. The focus now is very much on protecting against the major long-term complications: cardiovascular disease, CVD, and chronic kidney disease, CKD.
So it's not just about blood sugar anymore.
It's about blood sugar and organ protection. The new standards make this very clear. For patients with type 2 diabetes who also have established cardiovascular disease, like a history of heart attack or stroke, or who have chronic kidney disease, there's a strong recommendation to use specific classes of medications.
These are the GLP-1s and SGLT2s we hear so much about.
Exactly. GLP-1 receptor agonists and SGLT2 inhibitors. The key thing is these drugs have shown clear benefits in large clinical trials for reducing cardiovascular events like heart attacks, strokes, cardiovascular death, and also for slowing the progression of kidney disease. And crucially, these benefits seem to occur somewhat independently of how much they lower blood glucose.
So they're protective in their own right.
That's the understanding, yes. We're moving towards proactively treating the risk of these devastating complications right from the start, not just waiting until blood sugar is out of control. It's a much more holistic, protective approach.
That focus on comorbidities makes so much sense. Okay, finally, let's look even further ahead. The future seems incredibly personalized, maybe even down to the molecular level. We know T2D has a strong genetic link.
Very strong. Up to 90% concordance in identical twins, which is huge. But beyond known genes, what's really emerging now is the field of metabolite biomarkers, things we can measure in the blood that signal risk long before conventional tests do.
And this is where the amino acid research comes in.
Precisely. This is really fascinating stuff. Studies have shown that elevated levels of certain branched chain and aromatic amino acids, specifically isoleucine, phenylalanine, and tyrosine, can actually be detected in people's blood up to 12 years before they are clinically diagnosed with type 2 diabetes.
12 years. Before even prediabetes shows up on standard tests.
Potentially, yes. Long before their FPG or A1C, might cross the threshold into prediabetes or diabetes ranges, it suggests there are metabolic changes happening way, way earlier than we currently detect them.
That just opens up an incredible, unprecedented window for potential intervention, doesn't it? Maybe nutritional changes targeting those pathways or other strategies long before glucose becomes the main issue.
Exactly. It could completely redefine what we mean by early detection and prevention for type 2 diabetes.
So wrapping up our deep dive today, we've really seen a major evolution. From getting the initial diagnosis right, using the best test for the situation, to the absolute necessity of correct classification, using tools like autoantibodies and genetics to guide truly personalized therapy, and then the speed at which technology and targeted pharmaceuticals are transforming management is remarkable.
It really is. I think the core message is this decisive shift away from any kind of one-size-fits-all approach. Diabetes care is now about highly individualized strategies, leveraging everything we know about a person's specific type of diabetes, their genetic risk, their biomarker profile, and using advanced monitoring and therapeutic systems to optimize outcomes.
Okay, so as you digest all of this information, here's a final thought to leave you with. Building on that cutting-edge biomarker research, if we can potentially identify individuals at very high risk for type 2 diabetes by looking at amino acid changes more than a decade before their blood sugar even becomes abnormal, should our population-wide screening efforts eventually shift? Should we start focusing on identifying this kind of molecular risk long before we even hit those pre-diabetes glucose thresholds? The future of prevention might be less about managing blood sugar and maybe more about managing amino acids, something to think about.